After the four speakers, we'll have three of them here for a panel discussion for a broader question and answer period. So Becky, we want to indicate first we have no disclosures, and Becky will tell you about the purpose of this.
All right. Welcome, everyone. Thanks for joining us. This is a topic that's very near to my heart as both a researcher and a genetic counselor clinician who sees people with CF on occasion in the clinic. Today, we're going to explore the current data surrounding sort of the wide range of CFTR expression and function and how that relates to phenotype. It's long been postulated that there is some sort of threshold of CFTR function that should correlate with the emergence of clinical signs and symptoms, but that exact level of expression is difficult to determine, though many have tried, and we're going to hear a little bit about some of that today. And this sort of threshold also likely varies with individual tissue types and also with environmental or external factors, as you can imagine, which only complicates things further. So these thresholds will be explored by examining data from CFTR restoration using our outcomes from modulator therapies and also other interventions, as you'll hear today. Here's just a review of the objectives for our talks today. We're going to look at fundamental evidence in sort of the evolution and potential selection of CFTR mutations. This has been a hotly discussed topic through the years. Why do we have such a high frequency of carriers in many populations? We'll understand the clinical disease in CF and then also the CFTR-related disorders, sometimes called CFTRopathies, and the phenotypic penetrance of CFTR mutations in sort of non-traditional CF presentations, such as CRMS and CF-SPID. We will look at what we're calling wild type. You can tell I'm a mouse geneticist, right? So wild type CFTR inhibition through COPD and the potential use of CFTR modulators in those contexts. The third objective is to discuss therapeutic considerations regarding the spatiotemporal context and quantitative levels of CFTR correction that are required to improve some of the common phenotypes associated with malfunctioning CFTR, and look at modulator-related changes, including non-CF bronchiectasis like lung disease and altered microbiomes. So we are excited to have four different speakers today, and if I can do my tech part here. Oh, here, start. How about? There we go. Hardest part of my day. All right. I'd like to welcome Dr. Simon Graber here. He's all the way from Berlin to join us today for this talk. Simon?
Yeah, thank you very much for the introduction, and thank you very much for the invitation. I'm very honored to speak here today. And I'm about to tell you something about rescuing classical CFTR function. And the questions who I got was when, where, and how much. So these are my potential disclosures. So I think we all know that we now have CFTR modulators at hand to restore epithelial CFTR function. And as we know, we do have potentiators like ivacaftor and doit-ivacaftor. Ivacaftor is a monotherapy. And then we have correctors like lumacaftor, tezacaftor, elexacaftor, and vanzacaftor. And now we are about to 95% of people with CF that we can treat effectively with these modulators. I will actually mainly focus on ivacaftor and ETI in this presentation, but we know that we also have other modulators at hand. So let's start with the first question. How much CFTR do we need to rescue? And so for that, we first look at the natural history of CF, and we have registry data from before the onset or the age of modulators, where a registry analysis showed that patients that have sweat chloride levels below 60 millimolar show a higher survival compared to patients over 80 or in between 60 and 79 millimoles. Also, from CFTR function studies in intestine, we see that patients with a residual CFTR function in the range of 5 to 40% of CFTR function show milder disease with lower sweat chloride values, higher percentage of pancreatic sufficiency, and better lung function. And then we will hear a lot more about that in the coming talk. But we also know that slightly impaired CFTR function leads to CFTR-related disorders, so CBAVD, pancreatitis, bronchiectasis, and other pathologies. So this kind of gives us a little hint of where we might need to go with rescuing CFTR function. When we now look at the older data from ivacaftor, we could show that in the intestine it rescues CFTR function to about 50% of normal CFTR activity. And when we now look at recent data on the history after initiation of ivacaftor, we see that in all age groups, even after initiation of this highly effective therapy, there is still a decline in FEV1, which is more prominent actually in the younger age group, but it's also still present, a decline in lung function after initiation of this highly effective modulator therapy. So this means that in this case, 50% might not be enough at this time. Similarly, for elexacaftor, tezacaftor, ivacaftor, or ETI, we've seen that it improves CFTR function in the respiratory and intestinal epithelium to about 40 to 50% of normal CFTR activity. And in these patients, although we don't have any really long-term data and treat it from early on, but if we start this therapy in adolescents and adults, we see that it dramatically improves sputum rheology, here as the mucus elasticity, over 12 months. But if you see that little small dot here, it's the healthy controls. It's not returned to healthy levels. Similar for Pseudomonas density, we see an improvement over time, but it's not going down to zero. So we still have patients with Pseudomonas infections. And also seen in the inflammation, here exemplified by neutrophil elastase activity, where we see there's a decrease in neutrophil elastase activity, but not to normal levels, but here compared to non-CF bronchiectasis. So taken together, these data show that the improvement by ETI rescues those pathologies, but it still remains some disease. So where are we now? We are, with the current modulators, at about 50%, but I don't think this is enough. So when we look at the relationship and at the measurements of carriers and healthy controls, we probably have to go somewhere in the range of 80 to 100% of CFTR function. And as we know, sweat chloride-wise, probably way down below 30 millimole. We measure also always, as pulmonologists, lung function. And from this really nice data set from EDIT, we know that it does correlate with the sweat chloride, but we can also see that it might hit a ceiling effect here in the very low range of sweat chloride, meaning in the high range of CFTR function. So as a summary, I think we have this really big range of CFTR-related disorders that we see in the natural history. So I think with correcting CFTR, probably 80 to 100% should be the goal. But as I showed you, I don't have any real hard data to support this. And here again, similar to EDIT's data, we do see a correlation of CFTR function in the intestine and the FEV1. And here it is drawn like a straight line. But I think also here there might be a ceiling effect in lung function at about 40 to 60%. So then going to the next questions, and I combined those because I think it's very difficult when to start in which tissue. Again, looking at the disease manifestations, and I think we all agree that where I have problems caused by CF, that's probably where I would like to treat the disease. And let's start with the lungs. We know from measurements after newborn screening that about 20% of the children with CF have already bronchiectasis right after birth, and about 50 to 67% have airway wall thickening or air trapping. Also, inflammation is present right after diagnosis in newborn screening with elevated neutrophils, elevated neutrophil elastase. And in the functional studies, we see an increased lung clearance index in a subset of patients right after birth. This really shows that the onset of lung disease is at least right after birth, and I think this suggests that we should start early therapy here. But what do we know? There is data on children aged 6 to 11 years where we actually see that the lung clearance index, which is slightly elevated at baseline, is normalized throughout 12 months. So you could argue, well, obviously there are some pathologies, but treating at 6 years of age might be enough to really resolve all these issues. But if we look more closely on the structural side of changes, we can see that those dramatically improve with ETI therapy. But looking at the global score, which includes structural and functional findings, we see that it is improved, but there's still an increase in structural findings compared to 0 in healthy controls. Although the mucus subscore is actually substantially reduced and in the homozygous almost to normal levels. But we still have structural changes. So I think even in this lung disease, 6 years is not early enough to really restore all lung function. Next, jump to the upper airways. We know from in vitro and the in vivo data that it's about 50 to 60% of CFTR function that is rescued in the upper respiratory epithelium. And although there's not much data on the upper respiratory epithelium from the clinic, we actually see that pathologies are very well rescued even in patients that are treated at older ages. We don't know anything about the development of sinuses, which obviously is an important role even before the age of 12 years. But for all the data we have, 12 years might be enough, but my guess would be that here earlier is also better. Next, looking at the liver disease. Also, data here is very rare, and I think we need to generate more data on these questions. But there's a recent study from France showing that we do have an improvement in CF liver disease in the ETI era, here highlighted by the light blue color, compared to before ETI era in the dark blue. But again, you can appreciate this is still at about 10%. And not 0%. So I think here we even have to go earlier. And one study looked at the liver elastography, the liver stiffness in children aged 6 to 12 years. And actually it was normalized in almost all patients but one, showing that here for the liver, there might be 6 years might be enough. Although we have to keep in mind that we also do see children that are younger than 6 years that have really heavy liver problems. So this is a very small number. So I think also here we do need some more data. Next, looking at the pancreatic insufficiency. And that is something most of you are probably familiar with, data from the 2 to 5 years treated with ETI. And here actually some patients that improve to normal fecal elastase levels after 6 months of treatment. And when we look at the ivacaftor data from even younger children from the age of 1 to 2 years, we see that a larger proportion of patients go to the normal range. But we also see that the age of 1 year is not sufficient to get all patients to pancreatic sufficiency. And we also do not know the long-term effects on pancreatic insufficiency if started at this age. Now looking at the abdominal phenotype, we see that also in the intestine, the CFTR function is improved. And the only real data we have is from abdominal symptoms in the age group of 6 to 12-year-olds, which have a dramatic improvement in symptoms on ETI. But when you look at the color code here, we still have a substantial part that still has abdominal problems. And most of that, or some of that, is probably related to pancreatic insufficiency. So I think we can probably both tackle that together, but we don't know if that's really the only thing. And now, taking this to the next level, looking at meconium ileus, but also at congenital bilateral absence of the vas deferens. I think we have to take one step back and look at the animal models. And we do have really nice data here from in utero therapy of the ferrets, of G551D ferrets treated with ivacaftor or VX770. And we see that the untreated intestine looks really nice, but when the knockout, they really develop meconium ileus. But therapy with ivacaftor in utero prevents the meconium ileus. And very nicely, the early therapy also prevents CBAVD, which was actually very novel at this time. And now we actually have the privilege of having some human data on this. And there are actually two cases where we can treat in children with CF in utero. And one is pretty obvious, that we do have pregnant women with CF that are taking modulators and keep taking those modulators during pregnancy. And there are actually some cases published now that really take ETI from conception. And in those cases, no meconium ileus was observed. In 2 out of 2 male subjects, there was a palpable vas deferens, a negative newborn screening, and normal pancreatic fecal elastase. But sweat chloride levels were in the pathological range after birth. And what we also have to keep in mind, that that's only the time point after birth, but it's really critical what happens after that. Are those children able to get ETI via breastfeeding or through other mechanisms, or is it stopped? And what happens with the pathology afterwards? Because we know from the ferret, as soon as I stop the treatment, the disease comes back. And then it's really unique that we now have a set of children with CF or fetuses with CF that were treated in utero, but not from the beginning of the disease, but started around the 2nd or 3rd trimester, mostly because of hypoechoic bowel findings. And then treatment was initiated to prevent meconium ileus. Some of them were also treated without hypoechoic bowel findings, but that's most of it. And in these cases, meconium ileus was prevented in most cases, but not in all cases. So suggesting between conception and the 2nd trimester, there seems to be a time point where I might be able to prevent it, but maybe if I'm too late, or maybe other reasons, also maybe it's not good enough, I cannot prevent all meconium ileus. Actually, all patients had a reduced fecal elastase after birth. So again, apparently, it is not early enough to prevent changes in the pancreas. 2 patients were reported not to have palpable vas deferens. We actually just had a case in our clinic where we are able to detect the vas deferens by ultrasound. So that might be something that even with later therapy potentially is rescued. And these patients, probably related to the pancreatic stress, had mostly positive newborn screenings, and sweat chloride was mostly in the upper, in the pathological range, but 2 had sweat chloride levels below 60. And no cataract side effects were observed in these children. So taken together, I think we have some crucial data now showing that we have to treat as early as possible. And as early as possible probably means as soon as I know the child has CF, because we obviously, from theory, that's pretty easy, but everyone working in the CF clinic knows that's pretty hard. But that's what evidence suggests, at least for meconium ileus, the pancreas, and the vas deferens. And then one last thing I want to add, that timing is also might be related to how much is needed. And if we actually look at the clinical data, we can see that sweat chloride levels are lower in children aged 2 to 5 and 6 to 11-year-olds compared to the adolescent and adults. And that's pretty clear across all studies. And we have actually looked at the CFTR function in the intestine and observed the same thing. As I told you, in adolescents and adults, we see about 50% of rescue of normal CFTR function. But in the children aged 2 to 11, we actually observe near normal CFTR function after rescue with ETI. So maybe the time point of starting modulator therapy is not only a time point of when the pathology starts, but also the effects of modulators might be different. So in summary, I hope I could convince you that with the current modulators that are highly effective and rescue about 50% of CFTR function, we still have some residual mucus dysfunction, airway infection, inflammation, as well as some lung function decline. So the goal should be to reach about the level of healthy carriers or controls, so about 80 to 100%. And where and when is very complex, and we do need more data to really address that properly. But I think therapy from birth on might be able to prevent lung, sinus, and liver disease. And we know that early initiation can rescue pancreatic function in a subset of CF patients. But then really in utero therapy would be the best to treat the disease. And late or during pregnancy might prevent meconium ileus, but not CBAVD or pancreatic insufficiency. So we really start to treat at the conception level or before. And the age-dependent effects of CFTR modulators might even further increase the effects seen after early CFTR modulator initiation. So with that, I would like to close. Thank you for your attention, and I'm happy to take any questions.
Please use the microphones for questions if you can.
Hello. I'm wondering, what are your thoughts on the reasonings behind why we see more CFTR rescue when we initiate modulators at a younger age? What's the reasoning for more CFTR restoration?
Yeah, that's a very good and tough question. So I think, or I hypothesize that it's the remodeling of the tissue has more capacity. We actually know from natural history studies that CFTR function is also age dependent, also in the sweat duct, but also in the intestine. But it's not the level of CFTR at the protein level. So it might be the whole epithelium, which has more potential to regain its function. But that's unfortunately just a hypothesis, and I think we need to test that. Yeah.
Thank you. That was a beautiful review of the literature. I think it's going to be discussed maybe in one of the next talks, but could you comment on use of modulators in heterozygotes?
Yeah, I don't want to take the talk away. No, I think it's a very interesting question. And I'm actually very positive about that. And I think we should explore that, always depending on the pathologies the heterozygotes have. And the risk benefit of starting modulators and side effects. So, I mean, and costs, obviously. So there's, I think, a lot of balance, but from the physiological standpoint and the treatment effect, I think we do see, and you talked about thresholds. I'm actually not a big fan of thresholds because I think it's a continuum and they're in different epithelia, different problems that can cause, if I have 30% or 80% of CFTR function in one epithelium, dip to the other or not. So I think depending on that, it might be very interesting to treat these patients if they have pathologies.
I have a question about the VAS deferens data. I'm not up on the current thoughts on what the pathology is there, but I was always under the impression that it was an atrophy. Do you know from the ferret data or from other studies, if they're born with VAS, and then come off the drug, is there any evidence of damage postnatally?
That's a pretty good question. I don't know, but as far as I know, I mean, it's also a mucus obstruction. But if the mucus obstruction happens in utero, they are just really not developed well. So that I would guess that even after birth, that comes back. Maybe it's bigger after birth, so the mucus obstruction might not be that bad than in early development. But I don't know about that. Yeah.
Thank you very much, Simon. Excellent presentation. I really like the way you took it organ by organ, and it's fascinating how much difference there is. Here's the question. If highly effective modulator therapy rescues about 50%, but our target should be at least 80%. Is it fair to conclude that these drugs like ivacaftor and ETI are good but not good enough?
Well, that would actually be my conclusion. But then actually, I think we could also have a whole symposium on that, because if we now start very early, I mean, most of the data we have is actually starting in established disease. And that's what the ETI data I showed you on mucus dysfunction, that's on established disease. Although I was very intrigued by the ivacaftor data, that even in children below 12, it's still going down. So that makes me think that even if I start early, it might not be enough. But then again, if I see the data on the functional level, that in the young age groups I have 100% of CFTR function, maybe if I start that very early, maybe 50% at 12 years is enough to keep that going. Sure. I don't know. There's a lot of questions in my head which I can't answer, but a lot of interesting things, yeah.
All right.
Other questions?
All right. Thank you, Simon.
Our next speaker comes from Paris. My long-term friend and colleague, Isabelle Sermet, who works at the INSERM unit of Hôpital Necker and with the University of Paris Cité. And Isabelle is going to discuss CFTR mutations with incomplete penetrance as related to CRMS and CF-SPID. Isabelle?
Yes. So thank you for the kind introduction. So yes, we are going now to switch from conventional CF to CFTR mutations with incomplete penetrance. So I have no disclosure for this presentation. And what is really CRMS or CF-SPID, cystic fibrosis, transmembrane conductance regulator related metabolic syndrome, or cystic fibrosis screen positive inconclusive diagnosis? It relates to a positive newborn screen for cystic fibrosis in an asymptomatic child, who also presents either intermediate sweat chloride between 30 to 59 millimole per liter and at most one CF causing variance at genetic investigation, or a normal sweat chloride below 30 millimole per liter and two CFTR variants with at most one CF causing variant. CF-SPID is not a CFTR-related disorder. CFTR-related disorder is a clinical entity with feature of CF, mainly evident in adult life, such as CBAVD, but also including chronic or recurrent pancreatitis, isolated bronchiectasis, chronic sinusitis with or without nasal polyposis, and more rarely, aquagenic palmoplantar keratoderma. But in all these cases, it is associated with evidence of CF dysfunction that does not fulfill the diagnosis criteria of CF that can be defined by three different cases. Evidence of CFTR dysfunction in vivo or ex vivo in at least two different CFTR functional test types, such as sweat test, nasal potential difference, or intestinal current measurements, or evidence of one CFTR variant known to reduce CFTR function and evidence of CFTR dysfunction in at least one functional test type, or, last but not the least, two CFTR variants shown to reduce CFTR function with at most one CF-causing variant. CF-SPID is not a diagnosis. It is only a temporary label. Some patients can evolve to CF or CFTRD, but most will not. And it is very important to discriminate the patients at risk to evolve towards CF or CFTR-related disorder, because it is needed to implement appropriate follow-up in CF center for early pre-symptomatic treatment and also discuss access to CFTR modulators, while in the other cases, it is absolutely mandatory to avoid unnecessary medical interventions, discharge healthy infants to decrease parental anxiety, and in both cases, to implement adequate genetic counseling. So the ratio evolved from CF-SPID to CF or CFTRD has been explored in very, very few studies. So it is estimated for CF around 10% according to the different studies. And in any cases, these children who are going to develop CF are going to develop milder respiratory phenotype than in conventional CF. Most are pancreatic sufficient. And in some times, initial sweat chloride was above 40 with an increase of sweat chloride around the life and recurrent isolation for Pseudomonas aeruginosa. Risk to evolve from CF-SPID to a CFTRD has been explored in even fewer studies, estimated between 1% to 8%. And in most of the cases, these children are going to develop isolated, just diagnosed as CT sinusitis or bronchiectasis with recurrent bronchitis sometimes and bronchial colonization with Staph aureus. And so this potential evolution from an asymptomatic infant to children or adults diagnosed later in life with CF or CFTRD illustrates the continuum of CFTR phenotype spectrum from asymptomatic obligate heterozygote to patient with CFTR-related disorder, pancreatic sufficient CF patients, and pancreatic insufficient CF patients. Two important databases are exploring data, clinical data and genotypes for these patients. CFTR2, we all know CFTR2, which reports data from patients with CF enrolled in National Registry and CF Center. Around 90,000 CF patients reported in this CF database and around 1,200 variants online at the last updates. And it mainly documents the allelic frequency of variants in the CF populations. The second database is CFTR France, which collects data from the French CFTR genetic laboratories networks, enrolling nearly 6,000 individuals, but very interestingly, not only CF patients, but also patients with CFTR-related disorders, also newborn screen infants, including CF-SPID, and also, very interestingly, asymptomatic subjects with 2 CFTR variants, 1,200 variants online at the last updates, and aiming to report the phenotypic spectrum of CFTR variants, and also, very interestingly, the longitudinal evaluation according age in these specific patients. CFTR2 classifies CFTR variants in 4 main classes: CF-causing variants, which cause CF, one in trans with another causing mutations, variants with varying clinical consequence, which results in CF or a non-CF diagnosis when in trans with the CF-causing variants, variants which are non-CF causing, which do not cause CF when in trans with the CF-causing variants, and variants of unknown clinical significance. But you may note that genotypes associated with CFTR-related disorder can be found among variants with VCC variants, but also among non-CF-causing variants. So to avoid this confusion, CFTR France adds a new class, CFTR-RD variants, which result in CFTRD when in trans with the CF-causing variants, and this leads to a better targeted definition of the VCC variants, which results in CF or in CFTR-related disorder when in trans with the CF-causing variant, with the CF-causing mutation, and also highlights the non-disease-causing variants, which will not cause neither CF nor CFTRD when in trans with the CF-causing mutation or variant. So this continuum of CFTR variants from non-pathogenic to CFTRD to VCC and CF correlates to the continuous gradients, obviously, of CFTR function below 50%, the CFTR function of the obligate heterozygous, and probably between 5% and 30% of the normal CFTR function for VCC and CFTRD variants according to their residual function. And this wide range of CFTR activity combines with the other allele associating VCC variants or CFTRD with CF causing variants or VCC and enabling to construct this potential theoretical classification from CF associating with the non-disease causing variants to CFTRD, CFTRD, CFTRD VCC, CFTRD CF, VCC VCC, VCC CF, and CF-CF. Of course, this classification is very imperfect, and in fact, this reflects the probability of a given genotype to be associated with either CF or CFTR-related disorder, or also no symptoms in an asymptomatic compound heterozygous. And this relates to penetrance because VCC variants, depending on their CFTR function defect, may have a high penetrance to cystic fibrosis and a low penetrance to CFTR-related disorder, or for other VCC, a low penetrance to cystic fibrosis and a high penetrance for CFTR-related disorder, while CFTRD variants will have a high penetrance for CFTR-related disorder and a low minimal risk for cystic fibrosis, classical cystic fibrosis. But some CFTR-related CFTRD variants may have also a low penetrance for CFTRD and are mainly found in asymptomatic subjects. And indeed, penetrance is a statistical concept. It allows an additional specific classification for CFTR variants, and it is defined by the number of patients with the genotypes who express a given genotype, so observed phenotypes, observed frequency, to the total number of individuals with the genotypes in the general population, so expected frequency. And you better understand that when you consider the delta 508 homozygous genotype, which is mainly associated with cystic fibrosis for most of the patients. So the penetrance for cystic fibrosis for the delta 508 homozygous genotype is 100%. But this is totally different when you consider the genotype associating delta 508 in trans of D1152H, because some patients are going to develop cystic fibrosis, around 20%, but other are going to develop CFTR-related disorder, and some are going to remain asymptomatic. So the penetrance of cystic fibrosis is incomplete, and this reflects to the variable expressivity towards CF, CFTRD, or asymptomatic for this given genotype. So why is knowledge of penetrance important in newborn screening? Obviously, because it is important to accurately assess the risk of an asymptomatic neonate with a given genotype to develop clinical CF or CFTR-related disorder, notably in inclusive cases. And this is important now in the area of CFTR modulators to discuss indication of CFTR modulators accordingly, including very, very early, as Simon said. And it's also important when there is evidence of a VUS to define whether this VUS may be CF causing. So obviously the phenotype variability for a newborn screened baby is depending on the level of CFTR dysfunction, as we previously said. But we also must keep in mind that it can be associated with other genetic elements in the CFTR gene, in cis or in trans with the variants, and also differential level of NMD or splicing events, and also different isoforms of the protein. All these events are very, very underreported and underevaluated. At the individual level, it is also depending on various yet unclear factors influencing the expressivity of the genotype, such as genetic modifier, environment modifier, epigenetic regulation, as well as the genotypes. All these factors are very, very underestimated and not reported. But it is also depending on the penetrance of the genotypes, which can best evaluated by epidemiological data, including asymptomatic subjects, or also comparison between CF-specific database versus the general population, and also comparison between the CFTR-related disorder versus database reporting cystic fibrosis patients. And this is very, very nicely illustrated in the case of the R0117H mutation. And here I show the results of a French nationwide study where we studied 3,650 individuals carrying the R17H T7 in trans with the Delta 508 variant. And as you can see here, and unexpectedly, there were very, very few patients with cystic fibrosis reported, and also very few patients with CFTR-related disorder, including isolated CBAVD or CBAVD with other CFTR-related disorder. Most of the individuals reported were asymptomatic, and this led to reclassify this mutant in the CFTR France database as a CFTR LD variant with low penetrance, very low penetrance for CF and low penetrance for CFTR-RD, and also to withdraw this mutation from the newborn screening panel in France, and also to implement adequate genetic counseling. And finally, I want also to illustrate this concept with a study that more recently we did in France, where we wanted to investigate the likelihood of a positive newborn screening test, focusing on 5 frequent CF-causing variants, but mainly also on 10 variants which were found in CF-SPID, VCC or CFTR-RD variants in trans with Delta 508. And as an approach to evaluate penetrance, we assessed and we compared the variant allele frequency in CFTR2 database and in the general population, because obviously variants which are more frequent in the general population than in CF patients are predicted to be not CF-causing. And second, we estimated the likelihood of a positive newborn screening by calculating the ratio between the number of the babies born in this period detected with a given genotype divided by the number of babies expected to carry the genotype as reported in epidemiologic data in the general population. When we observed and we calculated the ratio between the general population and the CFTR2 frequency for a given genotype, you can nicely observe that there are genotypes which are much more frequent in the general population, T5, TG11, TG12, TG13, L997F, and R117H T7. What does this mean? This means that TG11, T5, for example, is 100-fold more frequent in the general population, and also these genotypes is 3-fold more frequent in the general population. This means that these 5 variants should not be considered as CF-causing because they are much more frequent in the asymptomatic general population. When we calculated the likelihood of a positive newborn screening, obviously it was very high for the CF-causing variants. But when we considered the VCC or CFTR-RD variants found in newborn screen babies, it was lower, ranging from nearly known newborn screen babies carrying the TG11T5 in trans with Delta 508 to 58% for this genotype, Delta 508 R334W. Again, what does this mean? This means that there are much more babies carrying these genotypes in trans with Delta 508 who are not detected through newborn screening, that these cases not detected do not account for false negative newborn screening. They are not going to develop cystic fibrosis. And while it is not really penetrance of CF, this may be indeed an indication for an incomplete penetrance for cystic fibrosis, but we did not have any insight for CFTR-RD. And to get more insight, we considered the CFTR France database. And it is interesting because indeed these database reports, as I said previously, phenotype according to the genotype and considered ratio of CF-SPID and also of CFTR-related disorder, CBAVD, bronchiectasis, pancreatitis, and also reports asymptomatic compound heterozygous for given genotypes. When you consider here CF-SPID in blue, you can observe that it was reported with a higher frequency trans with delta 508 for this genotype, R117H-T7, 5T-TG11, and L206W from 13% to 32%. But very, very interestingly, when we considered CF either diagnosed at newborn screening or later in life, this was mainly reported here for L206W and D1152H. When we considered CBAVD frequency reported among the 6,000 patients in the CFTR France database, it was mainly reported for most of the variants, but you can see here a gradient from 5T-TG13, TG12, R17H70, and also then down to the other variants. And this confirms previous reports, which were reported for the TG13, 5T, associated with a penetrance of nearly 100 for CBAVD, TG12, 5T being associated with a penetrance of 80%, while TG11, 5T was associated with a penetrance of 10%. We also studied the frequency of the report for bronchiectasis and pancreatitis, other CFTR-related disorder, and it was mostly reported for 5T-TG12 and D1152H, and unexpectedly for 5T-TG11 and L997F. But very interestingly, it was also reported in association with patients carrying also presenting also CBAVD, confirming the results of a very interesting Italian study published 2 years earlier, which reports that patients with CBAVD also do have bronchiectasis and pancreatic dysfunction when it is carefully investigated. Finally, asymptomatic heterozygous, they were highly frequently reported in L997F and R117H70 patients, around 10%. So how, based on this data and on previous reports, how can we classify these variants found in infant CF-SPID? And they could be placed according to their penetrance along this line. The 5T-TG11, L997F, and R117H70, mainly found in asymptomatic compound heterozygous associated with a very low penetrance of CFTR and minimal penetrance of CF, while 5T-TG12, 5T-TG13 is associated with a high penetrance for CFTRD, CBAVD mainly, also bronchiectasis and pancreatitis in a lower number of cases, while D1152H and L206W can be associated with CFTR-related disorder, but display a high penetrance for cystic fibrosis. And this is important because this also leads to a targeted discussion for indication of modulators, mainly in very early on in these patients carrying these two variants. So, but remaining very unknown factors, which is age, because we all know that penetrance is age dependent. We all know patients switching from asymptomatic infants to CF-related disorder and classical CF along the age. And this is really underreported factors. And to get further insight in this concept, we have implemented in France a study which is called ERANS, which you could translate as diagnosis wandering, focusing on patients carrying two variants of CFTR, at least one CFTRD or one VCC, aiming to study the variant expressivity along the age-dependent penetrance, and including, of course, the evolution of 405 CF-SPID now, who are going to be explored after 6 years of age by lung chastity, microbiology, by induced sputum, and pancreatic function. So in conclusion, indeed, predicting the probability of an infant CF-SPID to develop CF or CFTRD is complex. It depends on CFTR activity and penetrance of the genotypes. Other factors still unknown or under studies, including impact of age and sex, are important, and also additional genetic factors in the CFTR gene. VCC with high penetrance for cystic fibrosis display a high level of CFTR dysfunction. They may require access to CFTR modulators to daily progression very early on in life. While CFTRD or VCC with low penetrance for variants have a less clear-cut correlation between genotype, CFTR function, and phenotypes. They display a wide variability in disease presentation and evolution with age. The penetrance data are still mainly unknown because we lack studies. Benefits of CFTR modulators is still not proven, but we may have some discussion later on in these patients, and more data are needed to clarify this. And with this, I want really to thank my three wonderful genetic colleagues, Emmanuel Giraudon from Paris, Marie-Pierre Audrezé from Brest, and Caroline Reynal from Montpellier, and also Thomas Perrin, who is a junior CF doctor very interested in CF-SPID patients. Thank you, and I'm waiting for your questions.
Thank you, Isabel. We have time for questions. I should mention that Isabel has a commitment for another presentation later this afternoon, so she will not be able to join the panel. This is your only opportunity to question her or make comments.
Hi, Harold Levy from Madison. Wonderful summary. Great talk. So I have a question for you. Dr. Julie Biller this morning in the physician grand rounds presented a case of a 72-year-old who presented to her clinic with new onset cystic fibrosis. So I was wondering about your slide where you show age and epigenomics and environment and modifiers. Is there any way you can think about that in this patient and weigh sort of what was weighed more in this person's being able to live with classical CF without modulator therapies till 72 and just present?
Yes, absolutely. And so we do see that in the clinics because we have in Paris a clinics dedicated for these patients where we explore CFTR function in these patients mainly by nasal potential difference, sweat test, and beta adrenergic sweat secretion, which is in my mind, very, very interesting a CFTR function evaluation, which is not done in many places in the world. And we do see a normal sweat test, normal nasal potential difference, and abnormal beta adrenergic, even in asymptomatic subjects, but displaying this association of potentially evolving to CF or VCC or CFTR-related disorder. For example, last week we had a delta 508 TG13T5 who had normal sweat tests, normal nasal potential difference, and abnormal beta adrenergic secretion. And we do see a wide panel of patients at different ages. So that's why age is very important. But we do have other factors, either genetic or environmental. Sex also is very important in really influencing the expressivity of the genotypes. And we don't know barely nothing about that. And indeed, yes, I did have in my clinics 70 years old coming for diagnosis for cystic fibrosis, either because VUS or delta 508 D1152H. The clinician was so surprised, and indeed, it did have CFTR dysfunction, and it does have evolution to CFTR-related disorder, and potentially risk to implement cystic fibrosis. So I think the important point is there to acknowledge the risk, and the risk is there from neonatal screening, and that's why we really need to discuss the place of CFTR modulators to prevent the evolution even later in life. And that's, I also relate to ethical because we really need to balance the risk and the side effects in these patients because they may develop or they may not develop or they may develop cystic fibrosis or CFTR-related disorder later in life when we still don't know. This is very difficult to appreciate.
Thank you.
We have a number of seats here for those of you standing. There's some empty seats. And media expert Ian, you mentioned there was an overflow room. What room number is that? Do you know? Oh, okay. Never mind. Remain standing. There are seats here. I assured you out there.
Hi, thank you so much for your presentation. My name is Angel Wood, and I'm a genetic counselor in Genemacio in Florida. I just had a clarifying question. When you had your slides and you were the little pie examples of the different, phenotypes that we may present, did they have a disease-causing variant in trans with whatever the variant was listed on their pie chart? Or were they homozygous for whatever the variant was? I just wanted a clarifying question.
Which slide? Which slide?
Keep going. Those ones.
So yeah. So
are those all homozygous, or they have a disease
Those
causing?
are in trans. I say that they are in trans with delta 508.
Perfect.
And they are reported in the CFTR France database according to their symptoms.
I just wanted to make sure. Thank you so much.
Yeah, thank you, Isabel, for that excellent talk. I actually have a question regarding your diagram on the CFTR function level. Because,
I knew.
And I know, but I was, you show the CFTR function level of the asymptomatic heterozygous as at 50%, and I think that's obviously very genetic. So what are your thoughts that in the CFTR function measurements, we always see 80 to 100% across tissues? What's your explanation for that?
For obligate heterozygous, you mean?
Why? I mean, I'm on the genetic level. Obviously, we have one allele that is affected and the other is not. So I agree with the 50%. But on the functional level, in HBE cells, in nasal PD, and in ICM, we always see that it's 80 to 100% of normal CFTR function in the carriers. So what is your explanation on that?
So it depends if you look at the intestine where CFTR is highly expressed, and you do have also normally when you compare nasal potential difference, for example, and intestinal current measurement, we do have different level even for a given genotype. So it may be also related to tissue. So we did perform measurements in heterozygous, and we had also a wide range of CFTR function defects. Some may have a normal CFTR function as assessed of the very imperfect, I should say, CFTR functional test that we have. That's nasal potential difference and intestinal current measurement. Some may have 50%. Some may be even lower. So for the moment, I do think that this illustrates the wide range of the spectrum, even if in the obligate heterozygous, because as I said, and we did that with Caroline in a previous study, we underestimated, for example, variants, intronic variants, which can modulate the splicing of CFTR function, even in obligate heterozygous.
Thank you.
Your comment on the beta adrenergic sweat test reminded me of a comment from Simon during his talk, where he was talking about the potential that a goal of 80 to 100% of wild type might be the future, or might be what patients need relative to the 40 or 50% of function that they get out of ETIC sites. My question is whether or not you think, given the allelic combinations you described with normal NPD and normal regular garden variety sweat chloride, that you would see differences in beta adrenergic sweat tests, whether or not that might be a meaningful future thing to consider as an endpoint.
This I don't know, because we really discover, in my mind, in my experience, the potency of these tests, because it is really very sensitive to diagnose CFTRD versus heterozygous. For the moment, we did not see an heterozygous with abnormal beta-adrenergic function. So when we have abnormal beta-adrenergic function, we always say to the genetician, probably there is an additional mutation when we have only one mutation. And very interestingly, it is abnormal even for mutations which are associated with normal chloride function and abnormal bicarbonate function, for example, in genotypes associated with pancreatitis. So the Hanover group published improvement of beta-adrenergic after ETI. We did not study that because of lack of hands, I should say. In our center, we studied N103K, which was not associated either with improvement in sweat test, either with improvement in beta-adrenergic secretion. But I do think that we have much to explore this functional test, which is, after all, not invasive and implementable also in newborn screening babies.
Thank you.
It's just a clinical question as far as your expertise. So in the context when somebody with TG repeats or poly-T goes from having a normal sweat to an abnormal sweat, what's been your experience as far as how responsive that is to modulators? Often I'm disappointed with that response, and so then I don't exactly know how much to kind of continue to push the modulator in that context.
So that I cannot answer to this question, but just relate what I now these last 2 months enrolling patients from this ERRANCE study. So this was, I just reviewed 3 patients, Delta Fibroate R17H-T7, which were classed as non-CF, and we stopped following you 20 years ago. And so they come back to be evaluated within this study. So they have, one has, increased his sweat test above 60. One is asymptomatic. The other has pancreatitis. And the other has some bronchial syndrome at chest CT. All are now above 60. So I don't know what this means really, because this is only a threshold. This just means that in the sweat epithelium, in the sweat duct, the CFTR function has moved above 60, and that's all. This means, obviously, that there is a risk to develop cystic fibrosis because in the other tissues, there is a CFTR dysfunction, the level of which we don't know. May be different in respiratory epithelium and in the intestine. We don't know.
Thank you very much, Isabel.
All right. I'm pleased to introduce Dr. Tom Harris, who is going to present, we're switching gears a little bit to talk about some environmental factors now. Tom? From the University of Alabama. Sorry, I forgot the most important part.
First, I'd like to thank the moderators for allowing me to participate in such an exciting session. So my charge is to discuss environmental consequences on CFTR function, both in the context of COPD, but also other chronic diseases, and also with an eye towards how that helps guide us with modulator efficacy. So I'd first like to talk about, just do a quick overview, maybe an overly simplistic overview of the history of acquired CFTR dysfunction. So about 40 years ago, Mike Welch decided to give his dog a cigarette and see what happens. Actually, perhaps a little more sophisticated than that. But basically, he observed that in laboratory canines, they had an acute alteration in their tracheal potential difference after smoke exposure that was reversible. And then he subsequently did ex vivo experiments across tracheal epithelium and found that if he bubbled cigarette smoke across the mucosal side, he see a change in short circuit current, but along the submucosal side would not see that. About 30 years later, Rob Charon at UNC helped us understand the mechanism of that as far as maybe calcium-dependent, phosphorylation-dependent CFTR internalization in response to acute cigarette smoke exposure. About 20 years later in Canada, Peter Jury and other prestigious Canadian investigators saw a similar effect across the nasal epithelium in humans and saw that smoke exposure caused a blunting of the nasal PD. And as they explored the mechanisms, they saw that it was associated with CFTR expression, whether it be messenger RNA or protein levels. Closer to my institution, Vamshi Raju and Steve Rowe observed that the sweat chloride was altered in individuals that were exposed to smoke, and estimated that sweat chloride difference was about perhaps 70% of wild type. And then as the sweat gland is distal to the lungs, they actually hypothesized that there was a circulating modulator there. So they actually applied plasma to HBEs and found a similar reduction in in CFTR function. And then investigating that further, saw that acrolein was their hypothesized mediator of that. These observations really then basically bring up the consideration that in addition to COPD being like CF, that actually smoke exposure may cause a systemic acquired CFTR deficiency. I think we're all aware of, like in the lungs, there's mucus plugging, in the sinuses, there's chronic sinusitis. Again, in the sweat gland, we see a decreased function, but also there's, in smokers, is an increased prevalence of pancreatitis, glucose sensitivity, osteopenia, and infertility. And I'd like to really emphasize that although I'm going to talk a lot about smoke here, it actually extends in other contexts. So certainly there's always a common question like, well, no one smokes anymore. What about vaping? And we see the same effect. Perhaps the nicotine in the e-liquid is a contributor to that, but we see similar effects. And we see that also with other environmental exposures. And then circling back to the Iowa context, we also, and with the emphasis on the ionocyte, we also see that actually there's acquired CFTR deficiency in ionocytes, and this is now in response to, this is in the asthma context. And so to the left is Dave Stoltz's work, where he sees that IL-13 is associated with the loss of CFTR ionocytes, with some confirmatory studies from Australia involving interferon gamma, where again, kind of observing that there's loss of CFTR expression in ionocytes. And so I'd like to kind of, again, discuss that basically there's multiple environmental factors at play here. I like to think of this being kind of maybe macroscopic and microscopic. So from a macroscopic level, those are things like air pollution, diesel exhaust, ozone, heavy metals, arsenic, and viral infections, influenza and RSV. And those obviously cause a decrease in CFTR. But I also really think that within the lung itself, there's a kind of regional heterogeneity associated with disease. Again, we just talked about IL-13 and interferon gamma. I have an interest in TGF-beta, hypoxia, biofilms. All these cause regional variation in CFTR expression. So with the observation there's acquired CFTR dysfunction, and the utility of potentiators in CF care, well, then the obvious kind of question is, well, can potentiators reverse this? And certainly in preclinical models, we see lots of efficacy. This is kind of work from again, Vamshi again, where we see that in cells that Vertex or ivacaftor improves or overcomes this smoke defect. And that's also true of the airway surface layer and the mucociliary clearance transport. And then also in a COPD ferret, which is smoke exposed for 6 months, we see similar decrements in CFTR function that are overcome, this time with a Galapagos derived potentiator. So nasal PD improves, transepithelial current improves, mucociliary transport, the mucus viscosity improves, as does the airway wall thickness. But the human studies really had, to my surprise, the human studies really didn't show a significant benefit. And this is an ivacaftor study from K. Vijayakumar from, again, UAB, who showed no real significant changes in sweat chloride or lung function. And then also an additional study from Fernando Martinez of Novartis derived potentiator similarly showed just a very mild effect of like 35 milliliters, which is below the predefined threshold for significance. And again, I think some of this is that perhaps we kind of forgot the multiple mechanisms at play in CFTR dysfunction. So certainly there is a CFTR functional defect, perhaps from the acrolein and adducts that form with the CFTR channel. But remember that the CFTR is internalized, CFTR protein expression is diminished, CFTR transcript is less stable. So there's multiple factors at play. And perhaps that means that there may be other adjunctive therapies that could be helpful, although none of these have really been explored in clinical trials. So certainly antioxidants, I think we're probably all a little bit jaded about antioxidants, but certainly as far as addressing the acrolein or reactive oxygen species considerations, N-acetylcysteine has been helpful, again, in preclinical models, whether it be in cells or in animals. And then I always am interested in TGF-beta, where smoke activates TGF-beta that increases a microRNA called miR-145 that specifically degrades CFTR transcript. Hussein Owala from Miami basically utilized a TGF-beta, type 2 TGF-beta receptor aptamer to basically interrupt this process and overcome smoke inhibition of CFTR. And then Matthias Salath, now at Kansas, has utilized losartan to decrease TGF-beta signaling and also to show an increase in CFTR messenger RNA and ciliary beat frequency. In the last couple of years, I've become a little more interested in PDE4 inhibitors. So they're utilized for a lot of anti-inflammatory processes. They increase cyclic AMP, decreases cytokine expression, but certainly that increased cyclic AMP also helps CFTR expression. So Primulast or Flumilast, and again, preclinical models has been shown to be effective. Again, in clinical studies, probably not tremendously effective. So roflumilast has been studied in COPD. Not a huge improvement in lung function, about 60 milliliters, but perhaps in pre-selected categories of patients that are at increased risk of exacerbation, there's been about a 25% reduction in the odds ratio of an exacerbation. More recently, there's been the systemic PDE4 inhibitors sometimes have GI side effects. So more recently, there's been an inhaled PDE4 inhibitor, so has a little bit more smooth airway dilation. That has generated significant interest as far as in the use of COPD. Again, reduced exacerbations probably about 35%, as well as had a mild improvement in lung function. So there may be a role that they're being utilized for anti-inflammatory effect, but they may have an additional CFTR benefit. So switching those around a little bit, first part of the talk was looking more basically how smoke decreases wild-type CFTR and how potentiators might be able to benefit that, kind of flipping that a little bit to how smoke may decrease the benefit of modulators. We went back to look at urine biospecimens from participants in the GOAL study. And actually, part of this was actually to see an objective versus subjective measure. So we had the self-report of smoke, NAL, which is a tobacco metabolite, and 3-HPMA, which is an acrolein metabolite. And what we saw is that it was really the acrolein metabolite which was the most associated with the difference in lung function between smokers and non-smokers, as well as a really important difference in the ivacaftor response with regard to sweat chloride. So basically, in people who were unexposed or did not have high levels of 3-HPMA, they had twice the odds of having a sweat chloride that was less than 40 compared to those who were smoke exposed. And the difference between groups was about 12 to 13. Moving into combination agents, this is now kind of tezacaftor, ivacaftor, so a first-generation modulator. We again see that the effect of smoke was really to nullify the less effective modulators. So to your right, you see that basically the slope of lung function decline isn't changed in the smoke exposed, where there's a mild plateau in the unexposed group. And when we compare smoke exposed to unexposed at baseline, we see about a 3% difference in that lung function. But again, that's not changed at all in the smoke exposed. So smoke exposure nullified the mild benefit of Symdeko. Now, recently we've studied the benefit of or the consequence of smoke exposure on ETI, and we saw kind of similar effects, but kind of an interesting long-term or longitudinal change. So kind of coming in pre-ETI, we see again about a 3% or 2.7% difference between smoke exposed and unexposed, and then with a kind of a 0.03% change, so a slight that's the monthly change, and then with ETI, we see a parallel improvement of about 5.7%, and then ongoing improvements for the first 6 months. But after 6 months, we see a disparity between the smoke exposed and the unexposed groups. So the unexposed group kind of stays pretty much the same over time, but the smoke exposed actually resumes the monthly decline in lung function. So at the end of this study period, we see a widening of the disparity in lung function between the smoke exposed and the unexposed group. Similarly, for pulmonary exacerbations, we see the same type of thing, where we see that pre-ETI, there's about a 60% increase in the odds ratio of having an exacerbation in the smoke exposed group. ETI is beneficial to both groups, but less so in the ETI group, so that on therapy, the odds ratio of having an exacerbation in the smoke exposed group is now twice of that of the unexposed group. So these type of studies, we always try to control for sociodemographic variables, but there's always a question of, is it more to the environment than just smoke exposure? And the answer is, yes, there is more to that. Poverty certainly plays a role in other factors as well. But so we went back to the lab to preclinical models and investigated whether or not smoke exposure in the context of CFTR modulators had the same effects we see as far as acquired CFTR deficiency, and we saw the same effects. So a lower amount of smoke, this is kind of modeling secondhand smoke exposure. So a lower amount of, 1% cigarette smoke extract decreased the ivacaftor potentiation by about 50%, and we saw similar results as far as F508del cells as far as ETI. And then we saw decreased CFTR, increased TGF-beta signaling like we saw in different models. Now moving into rats who are exposed to smoke for 3 months, we saw a similar decrement in ivacaftor benefit. So certainly we had a significant decline in CFTR in the smoke-exposed animals. This manifests as a significant decrease as far as NPD, as well as tracheal short-circuit current, and also decrements in the periciliary layer depth, as well as mucociliary clearance. So then the question is, what do we do with this information? I think was always tempted, do we go back to another drug? But I think at some level, this tells us maybe we need to just kind of take another peek at enhancing our efforts to decrease smoke exposure in our CF population. So this is Gabriella Oates' work where and we've collaborated on this field of smoke cessation. And she found that basically in households, in the pediatric context, in households that had cessation of smoke exposure, there was a significant benefit in both lung function decline, where there's a relative plateauing compared to those who continue to have the smoke exposure, as well as a relative flattening of the exacerbation rate. So this kind of suggests that if we can stop smoke exposure, we have benefit. And this has prompted me to kind of wonder, why don't we emphasize smoke cessation efforts more in the clinic than we do? And this has actually been kind of one of my passions recently, as far as there's a lot of environmental factors that affect CFTR function, but smoke is really one of the most modifiable of those. And I think the literature really supports that physicians or caregivers, a lot of times we're pretty skeptical of the benefits of or the utility of smoke cessation strategies. A lot of times we think it's going to cause a lot of time or waste a lot of time in clinic, or that it's going to not be well received by families, or that it's might be ineffective. And what we did was, Gabriella, she designed a CF-specific trained tobacco specialist intervention in our pediatric CF clinic, where we basically first asked patients what type of smoke cessation study do they want. And so they told us a lot of the variables that we kind of refined. Then we had a trained tobacco specialist who was embedded in our clinic, but slightly separate to the medical team, so that I could kind of introduce the concept of smoke cessation, and that the trained tobacco specialist could kind of follow up on that. And what we found is that the reception to our effort was really positive. So there's a couple of things that we looked at in this study. So first of all, we wanted to look at the feasibility and the acceptability of a study. And our accrual or our enrollment for the study was very brisk. 60% of the patients that we asked to be in the study agreed. The participation continued throughout the study. There's no dropouts as far as the study. So we had 100% completion of the study. And then initially it was designed to be a 2-to-1. So we had 24 in the intervention and 12 in the education. But 4 of the 12 in the education actually asked us, could they have more intervention? And then we did questionnaires as far as how helpful they found it. And we had a tremendous response, right? So basically 70% of those in the intervention group found it to be helpful. 85% would recommend the intervention to others. And 89% of folks were satisfied with the intervention. So I think our fears of basically receptivity or altering a relationship can be abetted. And, we're very keen to expand this study on the outside. I guess then the second real question there, I think a lot of times physicians have a skepticism of whether or not smoke cessation studies might be effective. And this is a small study, again, 36 participants. So we can't really talk about change of lung function or maybe even change of sweat chloride. But we can talk about just a decreased exposure. at least 50% of the subjects, they tried to stop smoking. 17% of them did stop smoking. Cigarettes, self-reported cigarettes went down by a third. And then we had the objective measure of basically hair nicotine levels. So kind of a predetermined threshold of exposure is above 1 nanogram per milligram. And so going into that, in the intervention and the education group was generally above 2. And then we found that in both groups, actually, we had to decline to basically that threshold amount. So we see that basically intervention is effective. But then the secondary thing that is also I think encouraging is that even the education group, where we had a CF-specific education as far as the consequences of smoke exposure and what it means to be smoke exposed, even that was helpful. And then just one quick note is, given these conversations, a lot of centers say, well, I'm not sure about the smoke exposure rate in my clinic. And within the registry data, a lot of times that exposure amounts to about 15%. We in Alabama are a slightly poorer state, and there's an association with smoke exposure and poverty. So we're closer to 20% as far as our registry data. But as far as when the trained tobacco specialists kind of really dug deeply, we found that our smoke exposure rate was about 40%. And I would think that this is probably similar to other centers as well. So this is a really prevalent smoke exposure, prevalent exposure that perhaps is modifiable, that really has a significant impact on our CFTR modulators. So in summary, environmental factors such as smoke exposure really significantly limit CFTR expression and function. We talk a lot about smoke because that's modifiable, but there's all sorts of environmental circumstances or exposures that affect CFTR function. Modulator therapy alone may not be sufficient to overcome acquired CFTR deficiency. I think a lot of times we, as scientists, try to deduct a one mechanistic pathway where cigarette smoke has thousands of molecules in that, and so there's multiple pathways at play. Smoke exposure similarly limits the clinical efficacy of CFTR modulators. We're putting a lot of effort in putting patients on modulators. I think we need to put significant effort in basically decreasing smoke exposure. There's lots of novel strategies learned from the acquired CFTR dysfunction literature. I kind of mentioned 3 of them, and those also may be at play or may be applicable to improve modulator efficacy. But as a first step, I would say let's actually just really enhance our smoke cessation efforts. So this may be an important first step to improve CFTR modulator response. I'd like to thank the CFF and also the NIH for supporting this work, and I welcome your comments and questions. Thank you.
Thank you. That was really good.
Thanks.
So I was wondering whether the heads who are smoking are at higher risk of COPD, and whether you see a benefit to the parents as well when the household is involved in the CF study.
Yeah, so just to kind of clarify that, so first question, would CF heterozygotes be at risk of CFTR dysfunction? Yeah, I think the literature does support that. The second question is, would smoke cessation be beneficial to the caregivers? And I would agree with that too. I think I was really encouraged by, I think families know that too. I mean, again, I'm a pediatric pulmonologist, so it's a slightly different variable. But typically the parents, I think, are addicted to cigarette smoke or nicotine before they have the child with CF. And so I think they're very aware of that habit. They don't want to be ashamed of it, but they want to be helped. And so again, with CCF or our own experience, basically an honest, respectful conversation is typically well received.
Great talk. I've got a quick question. So what is known about the effect or the mechanism through which cigarette smoke extract decreases CFTR function? How much of that is mRNA based? How much is changing the half-life of the protein itself?
Yeah, it's a great question. And I'll tell you, the literature really is mixed because there's different ways that you can do it, right? You can actually kind of expose to smoke itself. You can bubble through cigarette smoke extract, cigarette smoke condensate, certainly there's, a significant literature about decreased CFTR function. There's a smaller literature about basically a transient kind of acute increase in CFTR function. And then, like I said, there's the different categories. So I think it's really, a lot of it's very much model dependent. I do think there's a difference between acute versus chronic. I think in the acute context, it's likely, and then also obviously, as we're learning about the ionocyte, there's basically basically there is both chloride secretion as well as chloride absorption. And then the IL-13 literature about Dave Stoltz, he was in asthma. He was more talking about basically alterations in the absorption. But I do think you can kind of separate a little bit of like acute response versus chronic response. And I think it kind of, in my context, as far as the smoke exposure, I would think a lot of it is kind of the chronic response. And I think certainly in our animal models, we see that there's decreased protein levels. And again, particularly some of those environmental factors, I mentioned TGF-beta, hypoxia, those are associated with microRNA that decrease the transcript stability.
Thanks.
Great.
Tom, are there data on marijuana exposures?
Yeah, I forgot to put that. It certainly is. I mean, not as much as cigarette, but I think we can think environmental exposures. Anything that you smoke is going to cause a difficulty in CFTR. And just back to the earlier response, at least the mechanism of that was, again, decreased expression. But I think some of the other mechanisms that require a level of sophistication as far as the analysis, sometimes association studies don't really delve into.
Thanks.
Great. Thank you.
Our last speaker is Rabindra Tirusanziam from Emory University in Atlanta, and he's going to discuss one of the most challenging questions about CFTR mutations in the context of CF carrier advantage. Were CFTR mutations selected along human evolution, and if so, why? Rabin?
Thank you very much. Thank you for inviting me.
I think you can go up to the top there and hit play.
I'm grateful for the audience also to be here, and I just freed up a seat in front. So if you want to compete for that one, there's going to be some selective pressure to get that seat. So again, really grateful for the invitation, grateful also for the three speakers before me because they made the job much easier, because what we're going to be talking about is not necessarily the very complicated diagnosis and how you take care of patients, or we're going to talk more about the cell and molecular biology, and also just dream a little bit of what happened when we first separated from rodents about 40 million years ago, or when we separated from primates about 6 million years ago, or when we came out of Africa about 40,000 years ago, and then when different human groups kind of populated the earth and evolved traits. So these are my disclosures. So I tried to break down the talk into three parts. In the first one, we're going to go over some basic concepts in genetics and review, for those of you who are not thinking about it all the time, what is carrier advantage. In second part, we're going to be discussing the carrier advantage in the context of CF and what people have done so far about this. And in part three, I want to propose maybe some new directions for research and hopefully spark some discussions, especially with our chairs. I know I've had some discussions with Professor Farrell over the years on this, and he's definitely an OG, as my kids would say, in the field. So I'm very, humbled to be presenting while he's watching me. So I'm going to try not to stumble. In part one, we're going to look at the fundamentals of carrier advantage, and I'm going to give you two examples of this that are well known in the literature. First one is major histocompatibility complex, which is an immune-related gene. And second one is going to be hemoglobin beta chain. So let's dive right into it. Fundamentals of carrier advantage. So you guys know about the theory of evolution. You probably know about competing theories in this country, but theory of evolution is still, I think, the most prominent among scientists. We have 5 ways by which genes can be selected. Sexual selection, like, antlers and horns and other displays that make one sex attractive to the other for reproduction. Disruptive selection. Let's say, for example, when you are a pepper moth and you are growing England in the 1800s, and the suit is making you visible for predators because you are white. Your wings are whitish. You will evolve very quickly gray wings. And then when you get rid of pollution, then the white wings come again. In that case, you have both disruptive selection, meaning appearance of a new trait, but you might have also directional selection. Okay. The other one is called stabilizing selection. Stabilizing selection is well known in population biology. We know among humans that children with low birth weight or very high birth weight have a high risk of premature birth and death. So evolution has really tended to make children with an average birth weight more, sort of valued for the survival of the species. So stabilizing evolution and directional evolution have the potential to decrease trait diversity. Disruptive evolution increases trait diversity. And then the last one is balancing evolution, so balancing selection. So balancing selection is a complex one, and that's what carrier advantage falls into. So what it does is that it actually allows for a particular trait to survive with multiple alleles. And when I say multiple alleles, it can be thousands of alleles. So you must have different ways by which this happens. So first case is there's going to be really no wild-type variant. And we're going to look at MHC, for example, and there's really no variant that seems to be performing better than the others. We really have a variety of variants, and they all coexist in the population. You have a second case where you have a clear wild-type variant and some mutant variants. That's the case of hemoglobin beta we're going to be talking about, and arguably that's the case of CFTR as well. And what's interesting to consider also is balancing selection can work along with the other types of natural selection. So now we're going to go a little bit over the different types of balancing selection, right? 5 types of natural selections, and then we're going to go over 5 types of balancing selection. Okay. So first one, heterozygote advantage. So I was telling you, you will have an advantage in certain conditions to have either multiple alleles or an advantage to having a wild-type allele and a variant. You have also a case that's called antagonistic selection. So that's known, for example, for certain traits that tend to be responsible for neurodegenerative diseases in older age, but happen to promote better function at earlier ages. And then we have a selection that varies over time and space. So we're going to be having some example of that with hemoglobin beta and arguably with CFTR as well. And then finally, negative frequency dependent selection. So this is an interesting one where very rare traits end up being maintained in the population. So I'm talking about rare traits. I'm talking, for example, of heterochromia. So this is the case of people who have 2 different eye colors. Or there's another one that I found while researching for the talk a little bit and trying to get a little bit of a chuckle or a laugh that's not induced by my French accent. It's about the uncombable hair syndrome. And I think one of my kids had that at some point, but then probably grew out of it. My center director over there, Niall McCarty, I think is a case as well of people with hair that are very difficult to comb. So how those are maintained in the population is very interesting. They can be through very specific selection. Let's say, some people might find it good to have children with people with uncombable hair right now. So that's one example. Okay, so we're going to go over several known examples of carrier advantage. First one, MHC, major histocompatibility complex. The trait is on chromosome 6. Actually, it's not a simple trait. It's a complex trait. There's about 280 genes that are expressed in this region, and it's critical for host defense. For those of you who are not immunologists, the MHC is the part of antigen-presenting cells that gets loaded with peptides, and those are then presented to helper T cells for development of an adaptive immune response. So it's very critical for host defense development of immune memory in long-lived species. It's highly, highly polymorphic, and I'm going to be showing here at the bottom the recombination rate that's been observed in the human MHC. And the normal recombination rate across the human genome is about 1 centimorgan per megabase. And for the MHC in certain spots, you see that it's definitely above 60. So you have a really, really high occurrence of mutations in this particular area. Why is it an advantage? It's because when you're heterozygote, you have different alleles in a lot of these different genes. You have a much higher ability to respond to diverse antigens and to present them properly. And that obviously will allow you to have overall better immune responses. What's interesting about this is that this family of genes exists already in primates. And a lot of these polymorphisms that we see in humans already exist in primates, right? So you're looking at a family of genes that was exposed to selection, including balancing selection very early on, before the split between primates and humanoids. And in humans, humanoids and in humans, the appearance of further polymorphisms have nothing but increased. So there's been a selection by time and space in the case of MHC. And there's no obvious kind of deleterious effect of having certain polymorphisms, except if you happen to be infected by the one pathogen that your polymorphisms don't respond to well, okay? But that's obviously rare. Okay, the second example is hemoglobin beta chain. So as you know, hemoglobin is the protein that binds iron in our red blood cells and allows for the exchange of gas. It gives the red color to our blood, and it's critical, obviously, for not only red blood cell function, but function of our bodies. I'm listing here 3 of the polymorphisms in hemoglobin, but there's many of them that are responsible for both alpha and beta thalassemias. Those can also be found, not exactly the same, but they can be found in primates as well. This is a gene family that's been under evolutionary pressure, again, for quite a long time. In humans, you have the S allele, which is found mostly in Central, East, and West Africa. This is a single nucleotide variation between GLU and VAL, position 6 of beta globin, and this leads when folks are homozygous to sickle cell disease. Hemoglobin C in West Africa, same site, different mutation, not a full-blown issue, but some mild hemolysis and anemia when inherited at the homozygous level. And hemoglobin E, this one is in Asia, different mutation, and also mild anemia. And what's interesting about all those 3 is that they reduce by quite a lot the severity of malaria in children. So for HBS, it's 90%. For HBC, it's 70%. So again, it doesn't prevent infection. What it prevents is for the infection to devolve into very severe, potentially fatal outcomes. So again, here, an example of selection by space. You can see 3 different regions. And you can see also now an example of what we call antagonistic selection, because on the one hand, the heterozygote state, having a wild-type allele and a mutated allele, gives you an advantage in terms of protection against a pretty bad infectious disease, but at the same time, it increases the chance that you're going to have some issues with the normal function of the protein. Okay, so now let's switch to CF and let's try to see whether it matches with any of those examples. So I'm not going to belabor that. We all know this. More than 2,000 variants known. Now 1,200 are known to cause CF. Between 80,000 to 100,000 patients with CF over the world, and about probably 20 million carriers. And very complex penetrance. So I'm not going to reinvite Isabel for her 20-minute talk to us about penetrance, because obviously there's a lot to learn about this. But what we know is that the penetrance is going to be different depending on the organs, depending on the age, depending on other loci. So some other polymorphisms might be co-inherited as part of haplotypes. So this is really complicated. What's also complicated is, and it's kind of a good illustration, if you just look at folks who are homozygous for delta F508, people have looked at monozygotic versus dizygotic twins, and they found that the monozygotic twins have more sort of relatable symptoms between one another than the dizygotic ones. So the effect of potential modifier genes, even though they have the same environment. And also we know in terms of lung disease, you cannot predict how bad the lung disease is going to be between patients with exactly the same mutations. Obviously complex penetrance. What we know about the CF trait carrier advantage, or we can guess, because we have more than 2,000 mutations that are known at this point, is that, first of all, there's probably a selection by space, because those are mostly seen in populations that are have their origin in Northern Europe. We also have a selection by time, because we know those different mutations did not arise at the same time from one another, and in some cases they are very rare, or just essentially linked to certain families. So there's this notion of what we call founder effect, where the mutation will be selected and maintained fixed in the population through just a few individuals. There's a good example, I think, with in the French Reunion Island, where some people came from Brittany, with the French colons. I'm one of the I'm not from Reunion, I'm from the Southeast India, but it's the same idea. The French went and they made a lot of people French around the world. So they went to the Reunion Island and they populated some areas that were mountainous and that didn't receive a lot of people over time. And certain mutations of the CFTR coming from Brittany basically got highly frequent in that population. It's kind of a founder effect, evolutionary bottleneck. And obviously there's antagonistic selection because, having two alleles makes you sick, and having one allele probably makes some things better, although we know that there's increased disease risk in CF carriers. We've been learning that. There's a beautiful paper by the team in Iowa in 2019 where they surveyed electronic medical records for 20,000 carriers and about 100,000 controls. And they found out of 59 CF-related diagnoses, the CFTR RDs that Isabel was talking about, they found increased odds ratios in 57 out of 59 of those diagnoses in the carriers. And the carriers definitely don't have better reproduction, which was sort of at some point in some papers in the 1950s, 60s was kind of proposed as a potential explanation. Obviously, if you reproduce better than others, you will have a selective advantage. This doesn't seem to be the case. In fact, risks of male infertility are increased by 5-fold in the hets, and bronchiectasis risk is also increased by about 5-fold. These are the two that are the most in-your-face type of effects of the in carriers. A lot of the others are kind of mid-range, 1.2, 1.5, 2. But definitely 57 out of those 59 have increased frequency. So why is it important? Is because there's a blurring of differences between the people with CF and the carriers. People with CF with HEMT can reach levels that are closer to the carriers, and then carriers now we'll be discussing to put them potentially on modulators, and we know also there's an age-related or smoke-related decline in wild-type CFTR activity that may cause disease over time. So what agents have been proposed as potential selective agents? Cholera was the first one by Cheryl Gabriel in 1994. The reason for it is cholera, Vibrio cholerae makes a toxin. The intracellular part of the toxin binds to adenine cyclase 6 that makes cyclic AMP, binds to the R domain of CFTR, activates it. Chloride is lost, water is lost. Cholera binds to the surface. The other members of the microbiota are flushed. So that's a good way, induced diarrhea is a good way for cholera to establish itself and also spread itself. CF carrier in those cases resist cholera, but right away, a year later, other CF carrier mice, again, both of them were knockout models, did not resist cholera. And then folks went and took gut biopsies of carriers, and they found they didn't have decreased chloride secretion. The other argument against cholera is that the history and geography of cholera and CFTR variants are largely not congruent. Another agent that was proposed is TB. So there was some really nice epidemiological modeling done by folks in the early 2000s. They found that about 2-3% increase in resistance to TB could explain the selection of the mutations. Dr. Tobacman proposed that this could be due to a defect in aerosol sulfatase B activity in the cells from patients with CF. And then a European Brazilian study in 2017 looked at different municipalities in Brazil and looked at where TB is endemic. And they looked at potential negative correlation between TB incidence and the frequency of carriers. Again, history and geography of TB and CFTR variants are better in terms of congruency than with cholera, but not fully. So where does that leave us? I got interested in plague for different reasons. My wife says I'm one, so it's one of the reasons, but not the only one. It's also called Black Death, pestis, blue sickness. It was the agent was found in 1894 by Yersin. It has caused 3 out of the 7 major pandemics in humanity. It's highly lethal in humans because humans are not the host for pestis. It actually grows and stays in small rodents. It doesn't care about humans. It shows actually because it kills them all. About 500 million deaths have been estimated over time in antiquity, in the Middle Ages, and there's still an ongoing epidemic. So in the Middle Ages, what we call Black Death killed about 60% of Europe and Asia. In antiquity, we know that pestis really led to, in part, the fall of the Roman Empire. At the time, Yersinia pestis acquired a mutation that allows it to stay at low temperature and spread in fleas. But before that, in the Bronze Age, we know now, this is when pestis was introduced in humans, it was airborne. Okay, it had probably about 100% lethality. Problem is, it's very difficult to go 4,000 years ago, 5,000 years ago and find traces of this. But we know that it likely exerted an enormous selective pressure on humans, probably from the Bronze Age and up until now. Very good evidence comes from very recent paleobiology. People came out of Africa into the Fertile Crescent and then populated this area, and from this a population called the Yamnaya came out a little bit later. They're known for their bell beakers, so they stayed them behind. They left them behind wherever they went. So paleoanthropologists can find them, but we know also they were the first population to domesticate horse, and they came very quickly through Europe on horseback. And Yersinia pestis is coming from a horse pathogen called Yersinia pseudotuberculosis. So we know now that the Yamnaya brought pestis with them in Europe. What we know also by studies of haplotypes of population in the British Isles is that within 1 or 2 generations, the Yamnaya haplotypes replaced the pre-existing Neolithic haplotypes almost by 95%. It's called one of the worst genocides in human history, and we know there have been quite a lot, unfortunately, in our history as a species. But this one was incredible. So a sweep, as we call it in genetics. Dr. Farrell and others, actually that's why he's one of my OGs, published this paper in 2018 that really sparked my interest, found that by analysis of 148 haplotypes in Europe, the Yamnaya people are most likely the ones who brought Delta F508 also to Northern Europe. We know that plague doesn't like neutrophils. And we know, this is work that I've done in my lab, that neutrophils in CF tend to acquire a really very novel fate, which we call GRIM. We are going to be describing that a little bit more tomorrow in workshop 22. But the idea is those cells survive. They release their granule proteins that are very toxic to pestis, and they promote self-renewing neutrophilia in the lung. This is not the first example of neutrophils protecting against plague. In Southern Europe, it's mutation of that inflammasome component called pyrin that is known to promote resistance to plague because that effector from Yersinia pestis, YOP-M, is not able to block activation of the inflammasome in patients. That has been shown in mice and in humans. And at the homozygous level, it creates that very bad autoinflammatory disease called familial Mediterranean fever. What's interesting is that FMF is in Southern Europe and CF is in Northern Europe. So they are potentially, a case of selection by space. So how might that work? When I was looking into this, my hunch was maybe it's cold climate. I'm a Southern Indian. I've been brought up in Paris. I can tell you it's not hot over there. Cold climate can create mucus through activation of TRPM8, and Yersinia pestis has a cyclic AMP toxin that it secretes that can actually block TRPM8, actually activate CFTR as well, as we know. So what's the effect? Let's look at the wild type first. If you are pestis, what you want is you want to be dispersed. So you activate CFTR, you block TRPM8, you disperse, you grow unimpeded for 2 to 4 days. At the time neutrophils finally catch up with you, you're everywhere. Neutrophils go everywhere in your lung and you die. That's the reason why people die of plague. Let's say you're a carrier now, and again, this is pure hypothesis, pure fruit of my mind so far, so take it for what it is. Lower efficiency flushing of the mucus. Bacteria are trapped, neutrophils come in early, they're magically cleared. And this is what we see actually in models where we have a little bit of neutrophilia, pestis cannot take. And that could be responsible for a really high evolutionary advantage. So what do we need to do? Well, we need to do more ancient DNA studies. Again, very difficult for Bronze Age, but we can look at Justinian plague, and we can also look for traits that will appear during the Middle Ages. More retrospective and prospective EMR studies, prospective lab studies, obviously. And we have to judge those hypotheses on CFTR variants based on whether they make sense in terms of space and time, historical events, and also founder effect and immigration effects. And there was actually a very nice study by some French colleague of mine recently where they looked at 3 different mutations in a population in Brittany that you could trace the ancestry of over 6 generations, which is really nice. And they were able to show basically that the different mutations provided different kind of modeled or estimated selective advantage depending on the years because of the admixture and more kind of diversity brought to the CFTR allele pool with time in a limited location. That's a pretty interesting study. So overall, I would say currently the model is that CFTR is and has been under a lot of selective pressure, both disruptive selection with the appearance of all these different variants and balancing selection with the maintenance of these variants, probably because of heterozygote advantage, antagonistic selection, differences in time and space, and founder effect. So we need to look at CFTR as a protein that's expressed in different cell types, obviously. I put my 3 favorite ones here, but obviously, there's other ones. Different effectors that have been linked to CFTR dysfunction and to defects in the heads. Different pathogens that might be involved, and different conditions that might be linked to CFTR dysfunction. So I'm going to leave it at that and definitely welcome some questions. I have a list of references here that really helped me put this together, and I can share that with the conference if you guys want that. And thank you for your attention.
Questions and comments?
Yeah, I've got a quick question. First off, that's an absolutely fantastic talk. I have a question. So if you're a carrier for Delta F, for example, you may have, a decreased propensity for a ballooning of neutrophil response to infection with Y. pestis, but couldn't it also be that because you have reduced levels of chloride secretion, that you might actually have an enhanced rate of adhesion or adherence of Y. pestis in the lung in the first place?
Yes, and that's actually a positive advantage as well, but it's not sufficient. You need to kill pestis.
Yeah.
Hi, that was a really intriguing talk. Thank you. I was just curious, you mentioned a lot, the variety of mutagenesis, right, among all of these different CFTR alleles, right, that people can carry. Do you think that you could actually attribute then, obviously some of them are going to be random mutants build up over time. If we've been carrying this for, hundreds of thousands of years, if not millions, then of course there's going to be a large variety. But do you think some of them, as we get better, environmental DNA and things that we can at least kind of piece together about the histories of those areas, that they'll be able to be tied to specific like geographic regions and outbreaks over time specifically, or they're just, there's only a few of them that are really tied to a specific disease or, reason, so to speak, or purpose, and the rest are just pure chance mutations that build up, across all genes over time?
Yes, it's a really good question. I think without question, probably the 5 most frequent mutations have been probably selected positively, and probably delta F508. And if we crack, I think, the nut for delta F508, then we can start to think a bit about the mutations that are a bit more rare. The thing also that we don't appreciate always when we look at multi-polymorphic genes like this is that sometimes mutation might arise and might not be wiped by evolution because it's silent. We see a lot of CFTR variants that don't cause any disease. So I think it looks like it's a hotspot for mutation. It doesn't look like it is because of its position in the chromosomes, for example, because we know some areas in human chromosomes, are bound to high mutations. This area where CFTR is doesn't look like it's the case. I would say I would be happy if I'm able to crack the delta F508 mystery first, and then we can work together on the other ones if you want later on.
Can we invite Simon and Tom up? And if there are any additional questions for all 3 of our presenters who are here, please step to the microphone.
I had another question for Ruben. Your point about selection in time and space is certainly interesting. And I wonder if there are any data on the exposure to pestis in different regions of Western Europe where we see variations in the frequency of CFTR variants. For example, the G551D, which sometimes called the Celtic mutation, but it has a very specific frequency. And I'm wondering if that might relate to an exposure like the pestis.
Yes, I think so. And we know that the Celtic region has been under probably the highest selective pressure, maybe because they were less admixed in terms of the Neolithic population prior to the arrival of the Yamnaya, and they were less resistant to plague at the time. But again, coming from France, there's something that's really interesting to me is that the kind of, France is divided in 2. There's really more of the Celtic people, Norman people in the north, and more of the, Latin kind of Spanish people and Italian people in the south. And you can really see that CF is really, again, still now, mostly in the north of France. It's still, there's quite a few people in the south, but it looks like some of those geographical exposures and selection of alleles have survived even the modern times where people have been moving around quite a lot. And I have to say something also striking in terms of exposure is that, to my knowledge, there's no other mammal or primate that has spontaneous mutations of the CFTR, while there are mutations of hemoglobin and MHC and all of that. So it looks like it's really a human trait, right?
Very good point.
There's another kind of human trait, and that is consumption of milk as adults. And that actually has been a hypothesis that possibly that provided some selective pressure for some of these CFTR mutations. Do you have any comments or thoughts on that?
Haven't reviewed that literature in detail, so I'll definitely go back home and read more. I've seen quite a few other things that are really kind of exotic. I tried to subselect so to say, the topics to cover based on having at least 5 or more papers that have focused on one potential origin for the selective pressure.
First of all, thank you so much. That was so great. I was looking forward to this since I first saw it on the schedule, and it was just as good as I was hoping it was going to be. So let's start with that. So my question was, you just threw off just now that CFTR has a high mutation rate, but I actually have heard otherwise. So I was wondering where you got that. And I will say the context of where I heard my otherwise is my identical twin sister is a geneticist, and she was in a case as an expert witness where the presence of CFTR mutation was used to prove non-paternity. So that would be what she told me. So now, and you said something different, but I don't actually know. So I want to know where you got that from.
So, Your Honor, I won't. I'll invoke the fifth. No, but I mean, I think it's really, it's a classic case of, we find what we're looking for in science, right? So we've been harping at the CFTR for so long. We know it so well. It's very difficult to know the level of polymorphisms of the 20,000 genes in humans. We know they make 1 million proteins, and we know they're highly polymorphic at the proteomic level. So clearly there's, that's why I was saying with a lot more genetic studies coming up with all these whole genome sequences being available, I think we're going to be able to say, okay, what's the real selective pressure and the ability to measure the quantity of variance of CFTR compared to other genes. But I think you have a real point. And again, I certainly won't go against your sister.
I will say it's a lousy paternity test that just looks at CFTR.
Hi, good evening. This is Anuja Pandey from CFFT Lab. Great talk to everybody, especially Dr. Harris and Dr. Rabindra. I really enjoyed both your talks. I'm just a little curious about, and you have it here on your slide too, Dr. Rabindra, about if CFTR patients, carrier CFTR patients have had any kind of advantage during COVID. If you can shed some light on that. And also to Dr. Harris, there was this whole thing about, I don't know if there's any literature yet or any research studies done, but it was seen that smokers were not getting infected with COVID as much. So if you both can talk a little bit on that. Just curious. Thank you.
Yes, there is a literature about the potential protective effect of CF patients during COVID. And I think that has been our clinical experience, that we were really quite wary of it. I guess I kind of, as a clinician initially, before I saw that literature, thought, that CF effectively is an airway disease, or at least early COVID was very much an airspace disease. I think some of those lines have been somewhat blurred now as we recognize the CFTR in the alveolar epithelial cells, and so there may be some consequence of that. And also, as far as to Becky's kind of area of expertise, and you may have some comment about that, with basically COVID adhering to angiotensin converting enzyme receptor, that was thought to be partially at play. I don't know if Becky or Ruben have any comment about that. The second comment was, or question was about smoke. Is that right? Remind me what it was. I'm sorry.
I had two things. One was if CFTR, patients with CFTR or carriers had an advantage during COVID.
Yes.
And the second one was, do smokers, smokers were said to have an advantage during COVID. And so you spoke about
Yes.
that. So yes. So that was a question for both you and Dr. Rabindra. Both
Yeah.
of these, yeah.
And I'm not quite as familiar with the smoke advantage during COVID, but I would just kind of, speculate that perhaps some of the acquired CFTR deficiency in that context, given the potential CF advantage during COVID, may have been at play.
Yeah, I don't want to bore everybody with immunology, but there's clearly something that emerged during the studies of COVID is that especially the fact that young babies or young children really are super spreaders, but don't really show a lot of symptoms. and they often have a little bit of neutrophilia in their lungs. In our own studies, we found that SARS-CoV-2 is actually blocking early neutrophilia and promoting monocythemia. The monocytes are responsible for the cytokine release syndrome. Flu does the opposite. So it looks like SARS-CoV-2 doesn't like neutrophils either, at least early on in the disease. But patients who have high neutrophilia later on, after severe COVID has occurred, are at higher risk of death. So it's kind of a similar effect that what we see with plague. Early neutrophilia, especially type 3 interferon signaling, looks like it's protective, and later neutrophilia looks like it's bad for you if you with SARS-CoV-2. That being said, studies on the HETs, I don't think have come up with an advantage, like population studies. And I've really put this one for Eric Sorscher, who's also a member of our center and who's been doing like a large study surveilling the EMRs, and they came up empty.
Got it. Thank you so much, both of you all. Thank you.
Thank you.
Hi, I'm Stacy Peters from South Dakota. I thought all of these talks were great, but I have a question in regards to carriers with non-CF bronchiectasis and how you find that magic point at which you can start labeling them as CF. Because I feel like it's different between peds and adults in how easy we give a diagnosis of CF. Like say you got a CF baby, newborn screen, they got a mutation, their sweats are in the 50s, you're going to keep following them. And then if they develop CF symptoms, you're going to treat them like CF. But in the adult world, you have somebody present with, say, non-CF bronchiectasis, you sweat them, their sweats are in the high 50s, they've got severe bronchiectasis, but you maybe don't have that other condition that you need to label them as CF. But yet, you know, they're presenting like CF, they've got the classic pathogens, all the things that we see. And when do you feel like it's appropriate that we can tip that scale to say somebody's CF without 2 mutations? Basically, when I look at like a few of our patients, we go through like the process of diagnosis and they land in the, what does it say, unable to determine or inconclusive diagnosis for CF. But yet you want to advocate for them to be able to get modulator therapy, but you don't have that CF diagnosis. I'm curious just to see if you guys have any thoughts on that. I have a specific patient who was in the Emory study and did very well on modulators, but now we're, fighting the insurance battle.
Yeah, so very, very good question and very tough one to answer. And I know there are a lot of guidelines also on CFTRD that Isabel mentioned a little bit. And I mean, we all want to have guidelines and have clear cutoffs that we can say this is this or this is that. But as I said, I don't think there are real thresholds. So, I mean, the advantage in our center, I have to say, I'm a pediatric pulmonologist, but we do treat adult and pediatric patients at our center. And I'm leading the diagnostic part. So, I mean, we have the advantage. We do have nasal PD and ICM there. So in these cases, I would always perform those measurements. And actually, if we see a decrease in CFTR function in these measures and we have pathologies, then, I mean, we're eager on calling it CF. But that's also insurance reasons. And then we have a lot of arguments to then prescribe modulators. So I'm really excited about that study coming up. I mean, there's one preliminary study in the ERJ Open showing that there are some beneficial effects. So I think that's an interesting concept. And I think we as a community have to kind of agree on when do we think we would like to start modulator therapy. And if the insurance companies don't want us to give modulator therapy to CF-related disorders, we maybe have to expand the CF of mild CF. I know we went away from atypical CF, but as long as it's called CF, we may be able to prescribe modulators.
I want to make sure we have enough time for everyone to get to the plenary, so perhaps we can.
I was just going to comment, it's very difficult to deceive insurance companies, but I like your idea. Well, I think we can wrap this up. Thanks very much to all 4 speakers, and thank you for your attention.